So I'm the chairman of this third session, provisional stenting, the ultimate approach. Oh, this is promising. And we have, the first speaker is again Dr. Nair. Is provisional stenting the holy grail in bifurcation lesions? Yes, I think so.
Well, hello again. I see that following my presentation, there are...
Dr. Yeleva is not there. Yeah. Okay, go on.
Yeah, after my presentation, I see there are many more presentations on this very same topic about provisional stenting. So what I will try and do is make myself more of an introduction so I don't overlap what the other speakers are going to talk about and steal their thunder. Holy Grail, of course, is an unattainable objective. Nobody has found the Holy Grail after thousands of years. So is provisional stenting really the Holy Grail? I didn't choose this title. Professor Gelav chose this title, and I'd like to ask him why he chose this terminology of Holy Grail in bifurcation lesions. So what is the scope of the problem, and what is our direction of discussion? What we know from all of these years of using drug-eluting stents, that the current generation drug-eluting stents are associated with very good long-term results in terms of patency, mortality, revascularization, etc. This is a very good option for simple, straightforward, non-bifurcating lesions. However, when we deal with bifurcations, as we discussed before, the picture is not that rosy, so that the MACE over a period of time doesn't look as good as simple single stents over non-bifurcating lesions, especially when you tackle bifurcation lesion with two stents. Now, because in the beginning these drug-eluting stents were found to be infallible, we thought that they are perfect, that nothing will happen. People started using it haphazardly, stenting whatever they could see, stenting many bifurcation lesions, long overlapping stents, etc. It was very much operator-driven, and each individual case did not have long-term follow-up, but when we looked at larger formal studies, it appeared that we were not doing the right thing. And generally it was felt that the KISS principle, KISS, keep it simple, stupid, is a good one to follow, is what everybody decided. And we have to be grateful to pioneering groups such as the people that are present here with the European Bifurcation Club, that looked at all of this very carefully and gave us guidelines, so we are where we are today, with a much better understanding of how we should use stents in more complex, especially bifurcation lesions. So what is the issue that we have recognized with two stents? Bench testing, cadaver model testing with two stents have shown us that the hemodynamics with two stents in bifurcation lesions is not as good as if you put one stent and just dilate the side branch. Even if there is no compromise, the hemodynamics seem to be better. So the shear stresses at the site of stent placement and at the site of the bifurcation is very different. Now we don't know how this translates to TLR in terms of stent thrombosis or stent restenosis, but clearly if we were to have better hemodynamics, logically it seems that that is the way to go. When we put multiple stents, there seems to be obviously more metal, more polymer, more drug at the bifurcation. And one might intuitively think that this is not good, that this creates more inflammation, etc. So this is not good. So we not try to overload the bifurcation with all of this material because we think it's really not good. Also, when we do these complex procedures with multiple wires, multiple recrossing, multiple balloons, etc., we have seen from bench testing that there is malformation of the stent. And again, this is not obviously good. And with certain kinds of bifurcation stent techniques, such as the V stent or the T stent, there could be osteal mismatch so that certain portion of the vessel, especially the side branch, is not covered, and that could be the nidus for future problems, including restenosis at this area. And of course, when we do these complex stent procedures, as we have seen before, there's increased radiation, there's increased contrast use, longer time, etc. And to do such complex maneuvering with two stents requires advanced training, skill, and the operator should have a lot of volume so that they are familiar with the techniques. What many of us seniors recognize is that many trained people are going out there without complete understanding of all the nuances, and they're all practicing bifurcation stenting, and one needs to be a little careful as to who does what. Now, we saw this data before, and what is the impact of two stents? In the syntax trials with the first generation drug-eluting stents done without IVUS support, without FFR, etc., we found that the outcome was a little less than favorable, and that influenced the fact that bypass surgery in multivessel disease, especially with bifurcation stenting, was better than PCI in treatment of multivessel disease. And in the syntax trial, you would see that 1/3 of the patients with bifurcation got stents, whereas in FAME3, where FFR was used as a guide to whether we should stent these bifurcation lesions, a very few number of patients actually underwent bifurcation stenting. And when you compare the two trials, albeit the first one, syntax, was the first generation paclitaxel-eluting stents, the FAME trials, FAME3 trials were done with second, third generation stents with much better drugs. So there is that little bias. However, the FAME3 trial with using other means of guiding our way of stenting with the current generation stents was associated with very few with very improved MACE effects. So that is an argument for using one stent and not multiple stents. It's clearly in our favor to do the latter. We looked at this already, and we realized that even when the FFR was positive pre-procedure in the side branch, you avoided stenting, and yet the MACE effect, when you look at 3 years down the road, was very, very much in favor of a single stent strategy. However, when we choose to do two-vessel stenting or single-vessel provisional stenting, one needs to decide upfront whether this lesion is good for provisional stenting, or should we upfront decide on two-vessel stenting? Clearly, there are situations where the side branch also has to be stented. And this is a very simple slide that differentiates major criteria and minor criteria that decides whether this lesion is complex or whether this lesion is simple. This is true for all bifurcation lesions 111, 011, 101. You divide these lesions into major and into true trifurcation with major criteria or minor criteria, dividing these lesions into simple and complex. And by and large, most complex lesion will require you to place two stents in whatever format you like, whatever technique you like, whereas the most simple lesions can be treated with the provisional stent. So when you study an angiogram, it is worthwhile deciding whether this is a complex lesion or this is a simple lesion, complex lesion, upfront strategy with bifurcation, stenting, and simple lesion, provisional stenting. So this is a good way to differentiate the two. However, there are some complex lesions that can be treated as simple. And we need to do that and not just be dogmatic and say this is a complex lesion at the left main bifurcation and we have to treat this patient with 2 stents. You don't have to be dogmatic because I'm making an argument that a single stent in most situations is better. So for example, if you have distal left main very complex stenosis, however, the LAD or the circumflex is well protected by a mature arterial graft, you can just stent the parent and the main branch and a side branch without using a bifurcation technique because the side branch is not protected with a stent. So you've made the procedure much more simple with a good long-term outcome. What happens if the side branch supplies infarcted myocardium with no ischemia? You really don't have to protect this branch. So for example, if you have distal left main disease with a totally occluded LAD, you can stent left main into circumflex, do whatever is necessary, IVUS, and you're done, making a complex procedure into a much simple procedure. And the third scenario that I think of is a situation where the side branch is diffusely diseased, a diagonal that is diffusely diseased that is best served with a single stent in the main vessel, because one knows that one of the variables that determines whether a stent will stay open or no is distal flow. So if your distal flow is poor because of very diffuse disease, might as well spare that vessel of putting a stent because a stent has a high chance of not staying patent. So these are situations where a complex lesion can be treated as a simple lesion. But when then the other way around, when does a simple lesion becomes complex? And very often this is because the side branch has a CTO that you may want to approach later. And this is very important if the LAD is totally occluded and you have distal left main disease. The ostium of the LAD is not involved, but if you want to treat the LAD CTO at a later stage, it is better to have access to that LAD lesion, and you may want to stent the ostial LAD so that working on the LAD CTO becomes simpler if you have a patent bifurcation, rather than going through a stent at a later stage. The stent has healed, and now you have to dilate the side strut into the LAD to get to the CTO. So in this situation, a simple bifurcation lesion is treated with 2 stents. Now, how do you anticipate? It's a very busy slide, but it basically tells you that the presence of a plaque in the distal bifurcation confluence, as well as plaque in the side vessels, and the angulation of the bifurcation can tell you whether one needs to do something to the side branch, either protect the side branch or you have a high degree of suspicion that you may lose the side branch, so you need to plan the procedure accordingly. So this could be in a simple lesion. However, one needs to anticipate the patency of the side branch at the end of your stent placement and part, so you can start thinking of how you are going to rescue this or how you are going to make sure that the side branch is protected, or you have access to the side branch if you do want to rescue it. So the presence of plaque and angulation of the bifurcation is very important in determining that. Now, this is very good to look at in cartoon format. How do you determine angiographically or before you start the procedure as to where the plaque is? It's very hard, and even intravascular ultrasound doesn't quite locate it. But this is good to think of. So if you do think that there is a high likelihood that the side branch will occlude, or you don't want to risk occlusion of the side branch, such as in a left main or a large diagonal LAD bifurcation, you may want to protect the side branch. And there are very many ways of doing it. And the simplest way that most of us do is by placing a stent. But depending on how difficult side branch access is, you can protect the side branch with an uninflated balloon, partially inflated balloon, fully inflated balloon, or using a microcatheter. So these are various ways that you can protect a side branch. And one needs to always worry about trapping the balloon or the wire. And I don't have to discuss how you can avoid trapping and how you can remove it. All of the experienced operators usually know how to do this upfront and how to salvage the wire or the balloon if it is indeed trapped. So this is an approach to provisional stenting. Again, I will not have to discuss that. You protect the side branch, you stent the main vessel into the diseased vessel, you do a part, see if the side branch is well protected. If it's compromised, then you need to save the side branch, and then you rewire the side branch. You dilate it, like I discussed before. You can dilate it with a non-compliant balloon or nowadays with a drug-eluting balloon, and then see what the integrity of the side branch is. And if there is decreased flow, if there is a type C or worse dissection, if the patient has symptoms or EKG changes, you may decide after a little while that the side branch indeed needs to be salvaged with a stent, and then you can put the stent. And depending on the angulation and your comfort level, you may use any one of the side branch stenting techniques, bifurcation stent techniques, and that is the end of the procedure. But remember, all the steps are important. You need to fully dilate the stents, you need to part, you need to do KISS, and then if possible, you should IVIS to make sure that the integrity of the stents and the shape of the stents and the apposition of the stents are all maintained. And this is especially true when you're dealing with the distal left main lesions. Now, how do you rescue the side branch if it is compromised? I think it's very important to know what the mechanism of the side branch occlusion is. Sometimes it is just a matter of carina shift, sometimes it's actually plaque shift, or occasionally there is thrombus. And so that, especially in patients with acute coronary syndromes, post-infarction, etc., it could be just migration of a thrombus. Depending on the mechanism, one can approach the side branch. So if you see side branch occlusion, you need not right away look for the stent. You can image this, decide what it is, and then treat the person accordingly. So if it's a thrombus, it does not require a stent. If it is section, of course it requires a stent. If it is just because that the stent strut in the main branch is overlapping the lumen of the side branch, it just needs kissing stents again, or do a proper dilatation of the side branch, part, and then kiss. Occasionally, if there is, especially of the osteomal side branch, it's very, very fibrotic, and it will not respond to your high-pressure balloon inflation or kissing stent. So you may want to use a cutting stent in that, or a scoring balloon, or a cutting balloon in that situation to get rid of the fibrotic lesion at the ostium of the side branch, and then finish it off with a balloon, and maybe this is a good way. And of course, we've discussed the role of drug-eluting balloon in these situations for good long-term results. Now, there are multiple trials that looked at single stent versus single stent, provisional stenting versus dual stent in these situations, and they use very many strategies, cool-out versus crush, and these are trials from Nordic bifurcation, BBK, Cactus, BBC, etc., all show that either the single provisional stent is associated with more favorable results, or at least it is not worse than dual stent strategy, again, in simple true bifurcation lesions. So a lot of these trials, but 7 of them, do suggest that this is a good way to go. And based on this, large societies have made recommendations. So that is a class 1A recommendation from before, with the AHA, ACC committees that recommended provisional stenting for simple bifurcation lesions, including left main. Provisional stenting is the way to go. And the more recent, in 2019, the ESC also made the same recommendation as a Class 1A, which of course is the highest recommendation. So provisional stenting is the way to go. So in conclusion, it is preferable to use provisional stenting in simple bifurcation lesions, and side branch, as we have seen, compromise can be salvaged with very many techniques. This person in pink is my daughter from 2 years ago. So this is in Colorado. Some of you are avid skiers, so I thought I would show this little picture. Thank you for your attention.
Thank you very much, Ravi. We have questions or comments?
Such a good presentation.
Yeah.
No questions.
Just a point about the side branch, the relevance of side branches. You have not said a word about the relevance. The relevance is what Ponconcourt discovered. When you have that more than 10% of myocardium coming from a side branch, then it has to be treated, has to be preserved. So preserved doesn't mean that you have to do decay crush.
Right.
You just have to keep it open. But I have to say, for example, for the diagonal branch, globally, 10% of them are relevant. And for marginal branch, 20% of them are relevant. So it means that the majority of cases, you have no reason to anticipate double stenting. I mean,
Right.
As a strategy.
Yeah. However,
it's interesting to understand that Xiaoliang Chen himself says that bifurcation lesions are treated in his center 70% with provisional and 30% with systematic decay crush. So this is near of this information. But what I see sometimes is what I've seen recently in a QCA review. I have seen decay crush in LAD with the third diagonal. You know, I have seen that. This is completely crazy. Don't do that. Okay? So very good review of.
Yeah. The one time about the one occasion where you may want to rescue side branch, if it is occluded and the patient is having symptoms. So, or it is compromised and the patient is having symptoms. Even though the vessel is small, you are expecting this patient to have leakage of enzymes and a diagnosis of myocardial infarction. But I would not put another stent, I agree. You just need to rescue.
You come with a microcat, as you said.
Yeah.
With the microcat is
correct. You can put
feasible.
nitroglycerin, you can do simple balloon.
After that, you do microcat, we put you put a very small balloon after that,
right.
reopen, and then you reaccess to this distal
So
branch.
you have to stay away from the side branch as much as possible, the side branch stenting as much as possible.
Thank you very much, Ravi. So, next speaker is Dr. Avramovic. Yeah. So, the title is Provisional Stenting in Bifurcation Treatment 2026, Rules of Engagement.
Oh, hello to everyone. Thank you, Valeri and Dobrin, to inviting me over here. Let's continue these talks about the provisional stenting, going from the Holy Grail to what we need to do. So I will talk about rules. Every stepwise approach has some rules, and also the provisional stenting has rules. So why this topic still matters? Because it's high risk. If it wouldn't be high risk, this topic would not matter a lot. Has higher restenosis, higher thrombosis, higher technical error rate, and it's still very much variable in how operators tackle this kind of technique. And do we need something standardized, yes or no? Yes, for sure. We do need a standard, but we can also have variability of how to tackle it. So is there something that has changed in these kind of years? Of course, we have way more imaging than we used in the past. Physiology is more accepted in treating side branches. We do have better lesion preparation tools, clearer complexity criteria, what is complex and what's not, and of course a lot of DCB use in the past years, which has changed dramatically the landscape of PCIs whatsoever. Just a fact check, this is the bifurcations. We do fear the 111 for sure of Medina, the others are so-so. And just to make it clear, the carina is not the plaque shift. So we move the carina and we move the plaque, whatever we do, but carina shift and plaque shift are two different things. So the provisional stenting is still the main strategy. The evidence, of course, still favors provisional in most bifurcations, and 2 stents are planned strategy for complexity, not the routine. So we're talking about rules. Rule number 1. We should define complexity before touching anything. So complexity determines whether provisional is default or conditional and should be declared before wiring. And what are these? When is the bifurcation complex? So Ravi already said, side branch diameter more than 2.5, side branch lesion length more than 10 millimeters. When there's heavy calcium, when there's severe angle, and there is a large myocardium at risk, so more proximal, and of course when there is left main involvement. Rule number 2, wire both but commit to one. So dual wiring means safety, nothing else. So wire both branches, do not pre-commit to side branch stenting or side branch intervention, and avoid reflex side branch predilatation, which is very, very common in last years. I will show you why. So when you have difficult wiring to the side branch, you do a double bend, you do pull back and recross. There are several techniques. You take specialty wires. For example, doing CTOs gives you a little bit more option of what wires are, and you can take maybe some wires that some other operators will not. You take angled microcatheters, especially the supercross, those which are more angled, like say 90 and 120, which are very useful. But there is one more, which is less than 90, but when you put a wire inside, this curve becomes less steep. Dual lumen microcatheters for sure, the Suzuki or the enhancer, which has a wider angle of exit of the side wire, or the last resort to inflate the balloon distally in the main vessel, so we do the block and support, and you can basically go inside the sand branch easily. Rule number 3, lesion preparation is a decision point, not just in bifurcation, but in all PCI. So determine success. You need to gain lumen. So many provisional failures are actually preparation failures. And if main vessel is not well prepared, the side branch compromise is basically at risk. So you need to assess calcium and fibrotic plaque. You can easily do it with HD IVUS and OCT nowadays. And based on this, you can do adequate plaque preparation. You do plaque modification, and you use scoring and cutting. I'm a big fan of scoring and cutting balloons because we need to gain lumen before addressing the final solution. That means stenting or DCB. Rule number 4, so main vessel always first, and we need to optimize it properly. So what are the main vessel stenting principles? We need to have adequate lumen gain before putting a stent. So we need to do a correct sizing. We can do it with imaging. We can do it without also, but with the imaging is better. We need to have full lesion coverage. We need to have good expansion. We need to do the dot, which is not mandatory. Some people do it, some people don't. So this is distal optimization technique. And the mandatory pot, which is not optional, but mandatory. Yesterday we have spoken about it, and there are figures that pot is performed just in like 20% or something like that, which is completely irrational nowadays. So what we need to take care about, the sizing diameter of the distal main vessel, the proximal, the pod diameter, how should we do it? We need to take care, number 1, of the carina, number 2, about the strut opening, and number 3, of the proper apposition of the stent in the main vessel. And of course, if we do in the left main, you have the guiding catheter over here, put a wire outside, which basically helps you not to get the guiding catheter too deep into the stent, and basically you can, let's say, they damage the main vessel stent. So, as I told you, POT is not optimal, it's a must. So we need to do the POT, the proximal optimization technique, because we need to have proper apposition of the stent in the proximal main vessel. And also, we need to, what we do with the POT, we open the strut to the side branch. And how to do a proper POT? We should not put the balloon distal of the carina, because then we don't do nothing. So what the correct POT is, the correct POT is that the balloon is put somewhere between the carina and the side branch takeoff plane. And there are studies that basically there is no difference where you put it, somewhere there in between. The mandatory is that you do it. And of course, you can do with the same balloon, you do the distal optimization technique, which is number 2, and the proximal optimization technique. And we do have very nice balloon, basically nowadays, that has like very short shoulders, and you can be very, very, very precise, and basically you don't touch the carina. If you do proper, very precise distal optimization and proximal optimization technique, basically you cannot have a lot of carina touching. Rule number 5, do not treat the side branch by angiography alone. So angiography pinching is not ischemia. So visual severity, like our oculostenotic reflex, is misleading. Carina shift often looks dramatic, but it's benign. So as I told in the beginning, carina shift is not plaque shift. So we make something when TIMI flow drops. There is severe dissection. We don't have symptoms or ECG changes. There is large side branch territory, that means circumflex, or there is physiology positive. So rule number 6, use physiology for the side branch, not just for the side branch, but also for the main branch. But, you know, because let's make it clear, you would not take a pressure wire just to make a side branch crossing because it's too expensive. Anyway, but when it's feasible, just do it. Pressure wire after main vessel stenting and can prevent unnecessary side branch PCIs. Rule number 7, imaging is your control system. So use it to size the main vessel stent, to confirm the expansion, to understand if the side branch is compromised, and guide POT and repot. I mean, imaging changes decision in bifurcation is more in straight regions, but it's especially useful, of course, in left main, and where it should be used like in 100%, not the OCT, but the IVUS anyway, and also that we have talked yesterday that there should not be a left main without IVUS use. What is the side branch treatment escalation ladder? So if side branch needs treatment, we go step by step. We do recross, first we do small balloon, repot, we consider kissing, we do repot if we do kissing, and bailout stenting only if required. So we don't do bailout stenting, you know, just at the beginning, just after, oh yeah, we see there the side branch, okay, let's put a stent. No. We go step by step. And Ravi showed this very nicely before, so I will not talk a lot about how to prevent and how to rescue the side branch. But one thing I want to talk about are the drug-coated balloons. So there was a DCB bifurcation trial shown on TCT, which showed 44 relative risk reduction comparing normal balloons in side branch dilatation versus drug-coated balloons. And this benefit was mainly driven by lower target vessel myocardial infarction. Since the use of drug-coated balloons went really high, what should we take care about? So the DCB treatment needs cuts and cracks for drug absorption. So we need to prepare either the main vessel and also the side branch. And with better expansion, we get less side branch compromise. We use scoring balloons more, also in the side branch. And we know that microdissections are acceptable, but recoil is not. And recoil and poor preparation leads to recoil restenosis and bailout stenting. So how to do the DCB in bifurcation Should we do it before or after? So DCB after main vessel stenting, of course, is the standard approach and was the strategy used in the DCB bifurcation trial. So the main vessel stenting and pot is performed first, then the side branch is rewired, pre-dilated with an NC balloon, and then treated with the DCB. This allows assessment of the side branch, of course, after main vessel stenting, but the limitation is possible carina plug shift before and after DCB treatment. So that means that we need to do reintervention on the main branch. So shall we do kissing after DCB? Is not suggested because every balloon inflation after DCB treatment gets the drug washed out. So it's a lot to talk about. DCB before main vessel stenting, what I see a lot nowadays, it's an alternative approach and has a theoretical benefit. So it's an optimal side branch drug delivery before mechanical compromise. So we don't have the carina or plug shift towards the main vessels. But what we lead with this approach that may treat a side branch that does not require intervention. And our oculostenotic reflex nowadays for drug-coated balloons is very low. And say, oh yeah, this should be treated. Oh, let's put a DCB before. Because everything nowadays is like, if it's like not really important, we say, oh, let's put a DCB down there because it will help. But this can lead to complications. So it was not recommended in the DCB trial, and it still remains investigational, although it's widely used, I can tell you that. So final casing balloon is selective, not routine, and we know how to size the balloons of the side branch and the main branch. And what are the common operator mistakes that we do? So now in the DCB era, especially treating the side branch too early, skipping pot, oversizing the side branch balloon, do not take the side branch balloon that is too big. Although if we do the DCB, we should take the balloon which is one-on-one, not the small balloon, not using the physiology and no using imaging in complex lesion, especially left mains. So what are the enhancements now or in the future? Of course, use of AI in complexity scoring. We know this from coronary CTs that we do have already some really nice scoring doing CT scans and perfusion scans. We do have better bifurcation balloons. I show you that. We have the workflows based on imaging physiology. We have the predictive side branch compromise tools. And of course, we have a huge DCB involvement, not just in side branch, but also having bifurcation treatment without putting any metal. So once again, the 2026 playbook. Assess complexity, one stent by default, wire both branches, main vessel first, mandatory pot, physiology-driven interventions, stepwise escalation, and imaging-guided decisions. So this is it, and you're all warmly welcome in Porto Roche if you want to come to the Cath Lab of the Future in March. So thank you very much.
I would add just a point. Everything you said is excellent, so nothing to change. About I forgot. So I'm very sorry. So you have to get this presentation in your cath lab. If you don't remember the steps, you put that on the wall. Everything is perfect.
Thank you.
Question?
Yes, please. Excellent presentation. Thank you. In your point of view, which the most strong predictor for a side branch compromising during the provisional stent? Is this sharp angle or calcification or something else?
Well, I think that is calcifications because, if you see calcium, basically you need to treat. Then how you treat depends on let's say, what tools you have. And of course, if you will do a lot of disruption or calcium plaque modification, of course, the side branch will be the one who gets compromised, especially talking about the circumflex and the left main. So we all hate hate the nodule in the proximal and ostial circ. We all hate that. And I think this is the main predictor of how the procedure will fail or not fail, but what will give you a lot of problems.
I think I will add to calcium opposite to the side branch. And I think when you see that, there is a risk of having closure of the side branch, for sure. It's a reason to properly treat this calcium
before anything. Yeah.
Just a couple of comments regarding the calcium. There is one OCT study and 2 CT studies regarding the calcium against the ostium of the side branch, which is predictor of side branch closure, just because it pushes much more stent opening to the side branch wall, and this is the reason of the side branch closure.
Mm-hmm. So the carina is also closing the vessel.
The carina is closing the vessel because the stent is pushed from this calcium and could not open against the side branch ostium. The second point is that I think that the position of pot balloon is crucial because of 2 reasons. The first one is that you can place the balloon too distal and to push the carina, and the consequences are sometimes very devastating. The second one is that even in the middle of the polygon of confluence, if you place the balloon there, because we made a lot of bench testings more than 15 years ago, it was so seen, and we published that in 2010, that when you do pot, the problem is that you make overextension laterally of the side branch ostium, and you are transforming circle into ellipse more, and we are squeezing the ostium of the side branch. So the position of the pot balloon should be chosen very carefully. Mm-hmm. And personally, from that time, I'm doing pot, placing the edge of the distal marker just at the place where the side branch wire goes behind the stent, goes into the side branch vessel. Because if you push the balloon, and this is a question of 1 millimeter sometimes. This is a question of 1 millimeter, and if you push it 1 millimeter distally, the consequence, even without pushing the carina, just because of the squeezing, this elliptical stretching of the ostium could cause side branch compromise, and now this is a plaque shift, but this is a plaque shift because of circumferential redistribution of the plaque into the ostium of the side branch. And this is 1 millimeter matters. Maybe it's a good message.
I agree. So provisional strategy technique can be done very quickly, but the time you have to spend on the position of the wort is crucial, of the pot is crucial.
Thank you.
Thank you. Another comment? No. So the next speaker is Goran, but Goran is not there. Goran, are you there?
Absolutely.
Goran, I miss you. I don't know why you are not here. So, but okay.
Because if it was just a ticket for 1 day, I think it's 1 flight a day, so I couldn't come and return the same day, and we decided.
No, I'm joking. It's nice to see you. So, you will speak about the recommendation of bifurcation on left-band treatment.
Yeah,
EBC recommendation. Thank you.
And thank you also to Congress organizers. Congratulations. 20th meeting is really a fantastic accomplishment. And we learn a lot each year from our colleagues attending BBC meeting. My lecture actually overlaps with many other which shed light on different aspects of stenting, and I'll try to stay within key messages that are probably not highlighted that much. You can see here 2 gurus, Yves and Patrick, and you can see also our new board members. Our meeting in Amsterdam in October actually resulted in restructuring of the EBC board, So we have Soledad Ojeda as a new board member together with Bong Kwon Koo and together with Carlos Collet. So we want to put more interest in the future in non-invasive assessment as well as in physiology. So there are two sections, multiple sessions covered what is through distal left main bifurcation treatment, and as it was presented in previous presentation, suggested strategy is of course provisional or inverted provisional, and in certain cases also side branch stenting first with preferably DK crush in comparison with mini crush and other modalities. And we base this decision on the results of EBC main 1 and 3 years, and we hope to collect at least mortality data for 5 years. As you can see in true distal left main, we actually have comparable results between provisional stepwise strategy and plan two-stent strategy with higher rate of TLR already at 3 years of follow-up in two-stent strategy. Provisional was described very nice, and I believe this is extremely important, and I'm sure that Eve will support that we should not decide up front whether we need 1 or 2 stents. We should follow the sequence of steps and make decision after each step whether we progress or we stop. In most of the cases, especially non-left main, we can stop after POT if properly performed. If we don't achieve good result with POT, we do kissing with or without repot, and if we need second stent, we continue with T-tap or culotte. And what we learned from EBC main, what was discussed this year, are 2 sub-analyses. One that clearly shows clinical advantage of provisional if circumflex is less than 3.25 and if lesion is shorter than 10 millimeters. So majority of lesions that we see, at least in Europe and United States, belong to this category, and provisional clearly has benefit. Steps were presented in the previous lecture, but I think the key is to understand that POT is actually mandatory step, while kissing in provisional, whether it's non-left main or left main, is optional. And for non-left main, we have 1-year outcome data from the KISS trial from Bernard Chevalier, who clearly shows that if after POT we don't have compromise in TIMI3 flow in the side branch, we can really stop at that point. We don't need to proceed with POT side POT or POT kiss POT because we don't gain, and actually clinical outcome at 30 days and at 1 year is the same whether or not we do intervention. If we need to do intervention, Francesco Burzotta presented in Amsterdam his CRABIS study in which he compared optimization strategies. As I said, one is to do POT side POT, the other is POT kiss POT, and the primary endpoint was imaging and minimal stent area in the distal part of the main vessel, in which this study clearly showed the benefit and better stent expansion as the primary endpoint if we do POT kiss POT instead of POT side POT. So POT kiss POT shows much better expansion distal as well as in bifurcation core, and also a position you can see was much better with kissing compared to POT side POT, and this is the suggested sequence and this will be published in JACC Interventions. I saw in the program that there is dedicated lecture to DCB in bifurcations, so I will just say that at EBC for the last 3 years we continuously have dedicated session, and we try to learn from experts, Prof. Kleber, Bruno Scheller, and we expect that our EBC DCB study that started last year with the primary objective to determine if drug-coated balloon treatment for non-left main true bifurcation disease is non-inferior to stepwise provisional at 1 year, as discussed now. This is the primary endpoint, cumulative cardiovascular death, target bifurcation-related MI, and target bifurcation vascularization at 1 year, but we will follow the patients at 3, 5, and 8 years of follow-up, because without implanting stent as a permanent implant, we expect better long-term results in the DCBR. And imaging was also commented, and in both sides of the Atlantic, it has class 1A for left main disease and complex lesions like bifurcations. Study is primarily based on the October trial. You see clinical benefit and 30% relative risk reduction with image guidance, but I saw that Eve will share actual EBC perspective that sometimes angiography, if properly done, can definitely reach. And we still need to wait another study. It will be presented next month at the ACC. It's the Optimum trial. It's actually very similar to October. It's just left main stenting with IVUS guidance as compared with angiography guidance. Adrian Benning, EBC board member, is a PI, and he will present data at ACC. And we really look forward to see if that study will be also positive or not. In case it's not positive, we need to discuss. But in the meantime, what we learn is that it's much more important to properly use the imaging than just use imaging or not. And together with EAPCI in 2022, we started writing together this document with the guidance of Tom Johnson, and we are still, because of some discrepancy between EAPCI and PCR, now we have problems to publish this in neurointervention, so it's still under revision. But to share with you some of the highlights, in this document we clearly define how to properly use imaging, for example, pre-procedure to determine landing zone, stent length, and stent platform, and also need for plaque modification, and if we do modification, we need to repeat imaging, and we can also discuss imaging criteria for use of stenting to stent technique. So extensive disease of circ, more than 10, significant calcification, as it was already discussed, requiring advanced plaque modification, and high risk of closure with very large territory are probably situations in which planned two-stent strategy should be used up front. And regarding the optimization criteria, we went from the rule of 5, which predicts actually 9-month rate of target vessel revascularization. After Excel and after the Excel trial, we see that criteria are actually much larger. And now these are the criteria from the new consensus. 10 to 12 inside the left main stent area, 7 or 8 or more, of course, at the ostium of the LAD, and minimal lumen area more than 4 at the ostium of the circ by imaging, or if we put stent more than 6 or 7 millimeters. And finally, the study that impacted and created actually the program after the meeting is this sub-analysis from EBC main, in which we analyzed the restenotic cases, and we understood that 60% of restenosis is at the ostium of the circ, and when stratified for two-stent strategy, again 60% circ, or provisional with single stent, almost 60%. So circumflex is definitely the Achilles heel of left main PCI, and we will dedicate the consensus this year mainly to treatment of ostial circ, and these are some examples, and we have dilemma how to treat. According to angiography and according to imaging, it's rare, it's 6 to 7% of all distal left main lesions, or for the ostium of the LAD, 8 to 11%. But when we look feedback from multiple registries, these are two largest, E-Ulti Master 4,000 patients and Bifurcat 8,500 patients, we see that presence of 001 is low, less than 5%, but when we look the rate of adverse events, you see that 001 has the highest MACE rate compared to any other lesion subset, including 111. So it's difficult to find the ideal treatment with stent for osteal circ. According to anatomy, nailing the ostium could be simple, and this is just one example with OCT, and when we rotate now, you can see that in favorable anatomy with expertise, you can really precisely, in some cases, stent the ostium, but most of the time, actually, we either miss the ostium and have gap, or we protrude inside the left main. And this is such example with precise stenting, good and geographic result, but when patient came back for LAD PCI, it was difficult to cross into the LAD, and this is the explanation why you see in red, and you can understand this is the LAD, the third, that actually stent is completely covering the ostium of the circ. So how to treat isolated osteal circ? This is what Francesco Burzotta presented, either in precise osteal stenting with nailing the ostium, or inverted provisional stenting from the left main into the circ, so precise, or stenting with pot and then kissing. The reason is that there is almost in 2/3 of the cases plaque extending. What angiographically seems to be 001 actually is plaque starting from the left main into the circ, and this is a bench, crossovers from left main into the circ with pot, distal recross and kissing, and final pot actually gives optimal coverage and optimal expansion inside the left main. So these are just two case examples with OCT guidance. You see that there is diffuse disease and no landing zone for precise stenting at the ostium of the circ. This is the LAD from the OCT evaluation. You see that there is healthy ostium. So balloon predilatation, crossover stenting, pot, and after pot, NC balloon, distal rewiring, and then simultaneous kissing balloon inflation, and this is inverted provisional, and also in the other projection, and by OCT, excellent areas, 12 square millimeters inside the left main, without compromise of the ostium of the LAD, and also no dissection. The other option is to use DCB. What we know from multiple registries is that DCB compared to POBA has much lower late lumen loss. So maybe the idea, like in this case, preparation and for circ and then DCB for 60 seconds with good result, acceptable, and with OCT confirmation before and after PCI that there is no compromise of the LAD, no major carina shift, and you see broad opening, will be tested in the randomized study that Francesco designed for multiple sites in Italy and 3 sites in Serbia. And it's drug-coated balloon versus stent for side branch interventions in Medina 001. And this includes large bifurcations also outside of the left main. And aim is to compare safety and efficacy of DCB only in 001 in comparison to inverted provisional or side branch osteal stenting. Its strategy trial, randomization will be done before lesion preparation, and for non-left main bifurcations, distal main vessel should be large, more than 3.5, side branch more than 275, and then we compare provisional with drug-coated balloon. These are the study devices. Medtronic will give a grant, so Prevail and Onyx will be devices, and primary endpoint is net adverse cardiac events at 13 months, composite of ischemic and bleeding, because with DCB we expect shorter DAPT. So I would like to conclude that at 21st Bifurcation Club meeting, we remain the promoters of stepwise provisional as optimal strategy for most bifurcations. We realize that isolated osteocirc is difficult to treat. Spot stenting could be compromised by too much protrusion into the left main, so we believe that inverted provisional stenting should be suggested. But also DCB with lesion preparation with cutting or scoring can be alternative. We need to get the results of the study. And we definitely believe that optimal PCR result with full stent expansion and deposition should be our goal and should ensure good clinical outcome regardless of whether it's achieved with angiographic guidance or with intracoronary imaging guidance. I thank you very much for your attention, and I will be happy to answer any question you may have.
Fantastic lecture, Goran. So, have you questions or comments?
Congratulations, excellent presentation, as always. I have a question about the lesion preparation in this, especially this case scenario 001. Because if we want to have a good result with DCB, it's obligatory to have excellent lesion preparation. And in this special place, osteocirc, it's really challenging to have a really good plaque preparation. Do you have in your mind some pitfalls that we should know about the preparation of the lesions in the osteocirc?
Yeah, we need good lesion preparation, as you said. We need some dissection in order to be able to deliver drug, but we can only advise use of cutting or scoring. In severe calcium, of course, more severe calcium, Monday's dedicated, maybe rota or IVL if needed, but definitely what we can define is acceptable lesion preparation, which means residual stenosis less than 30% and no contrast staining in the vessel wall during cardiac cycle with TIMI3 flow. So if you are able to achieve this criteria, so lesion less than 30%, no staining in the vessel wall and TIMI3 flow, we believe that DCB should work.
Any other question? No? Thank you very much, Goran. Take care of your throat. And see you soon. See you soon.
Thank you and see you soon. Bye-bye. Successful meeting.
So the last presentation in this session is by one with Chico. We'll explain why you are changing your name each time, you know. Yeah. And of course, we are coming to the what will be the future, probably, at least the future of trials, which is the drug-coated balloon in bifurcation lesions, totally DCB, with left main or not, or only for side branches.
So, okay. Thank you very much for the invitation. Professor Gil started the morning saying, try to provoke us, to irritate us. So now it's my time. I guess you will. You will be. So let's start by doing some general considerations about the therapy with drug-coated balloons that sometimes are forgotten. First of all is that each drug-coated balloon is the combination of the drug, which used to be only paclitaxel, but now we have new players on that, and the carrier, very important. The carrier is instrumental to transfer the drug into the vessel wall. So as you can see here, we have now multiple options, and in this case, as in many other ones, but in this especially, there is no class effect, because one balloon can be very good, but other one can be not. And also important, the drug which works very well on the stent does not need to work very well also on the drug-coated balloon. They will have to prove it. Maybe the paclitaxel, which is part of our history in the drug-eluting stents, maybe it's the best one working on a balloon. We don't know. We don't know yet. The next consideration is that we try to avoid geographical miss. So just to adjust the length of our drug-coated balloon application to our target segment. But we have to keep in mind that there is, at least in animal studies, there is also longitudinal diffusion of the drug. So, especially when we are treating bifurcations, maybe we don't need to be so precise in applying the balloon. If we miss half a millimeter or so, according to the animal studies, it could also diffuse longitudinally. So we should be fine. Another consideration that I have repeated several times, and we have seen just slides pointing in the opposite direction, is that late lumen loss is not a valid endpoint for a study to compare a balloon with anything. The late lumen loss was developed by Laura Mori to compare one stent versus another stent, because then the gain is similar. And then the late lumen loss becomes a valid surrogate that spares sample size to compare stent versus stent. But we cannot use late lumen loss to compare a stent versus a balloon, or a balloon versus another balloon. And I mean, when I was a fellow in Rotterdam, you come to know very well the publications of the group, and this was the Bene stent, the first study that demonstrated the usefulness of stenting versus balloon angioplasty, what we would call today POVA versus bare metal stent, and see how the stent was superior to ballooning in clinical endpoints and in restenosis rate. But notice how the stent had higher late lumen loss because it had also higher gain. So if you gain more, you lose more. So you can forget any study about drug-coated balloons reporting late lumen loss because it will be misleading. Actually, Goran has just shown this. Notice how you are using this to compare between balloons and stents, between different ballooning strategies, and notice how no single one is significant. It will never be. And if by chance it could be misleading. You cannot take any decision based on late lumen loss on a balloon study. Important. The drug-coated balloon should be the last step in our strategy. So that means no imaging after the drug-coated balloon. I remember when I was in Rotterdam, we ran the first DCB study with an OCT endpoint. And when I went to Patrick's house to show him the results, and he saw that they were kind of discouraging, I remember in his penthouse, he said, I don't know, I don't understand very well why, but all the positive studies with drug-coated balloons have been done with angiography. And when we try to add IVUS or CT, they become negative. And now we have evidence. I will show you at the end why this happens. So no imaging after the drug-coated balloon. Maybe we are scratching the drug and losing the efficacy of it. And the last problem is that we are going now to go through some studies, and you will see that the evidence is inconsistent. Each group, each study is following a different methodology. Some of them are skipping some steps that other ones are following one, so it's very difficult to compare. We have very different devices, combining drug, carrier, etc., but also the methodology of the groups is very different. So maybe there is an opportunity to define a standard methodology, because otherwise we will get confused and we see that one study is positive and other one reporting apparently the same is negative, etc., and we have to look very carefully which methodology has been used. So, What's the rationale for the use of drag-coated balloon in bifurcations? Mainly, the summary of all this is that it allows us to reduce the metallic burden. So it is consistent with the provisional strategy and the KISS principle. Keep it simple and safe. I like the keep it simple and stupid. But basically, we know that two-stent strategies increase the risk of maze, of clinical events, and we should avoid them whenever possible. And the drug-coated balloon is a reasonable way to be consistent with this provisional strategy whilst delivering targeted drug to the side branch, which is a main focus for complications and for restenosis. Also, there are some other potential advantages. Sometimes the side branch is too small as to implant a stent, and maybe the treatment with this drug-coated balloon seems a reasonable option. We might have some positive remodeling in the whole bifurcation, etc. But we should also acknowledge that doing treatment with drug-coated balloons properly is more technically demanding, because kissing is discouraged, and then the point of delivering the drug efficiently while keeping the geometry of the bifurcation requires some technical skills that are not required in a different kind of strategies. So, regarding the question that was the subject of the presentation, should we use drug-coated balloon standalone, like in the planning EBC trial, or just to treat the side branch? Some general considerations about the rationale for each one of them. If we are using standalone, probably the predilation would be mandatory, whilst if we are going to treat the side branch, should be discouraged, at least before implanting the stent. The risk of carina shift probably in the standalone technique is low, whilst if we are using provisional, the risk remains high, like in all the stents. Right now, the treatment with drug-coated balloon of de novo lesions is not endorsed by any guideline. We are now having evidence, and maybe the guidelines will change. I think they shouldn't so far, but maybe they will change. Whilst you have freedom to treat the side branch with a coated balloon. I think the standalone technique may be appropriate for this challenging scenario of the 001. Probably is the best option. We don't have compelling evidence about that, but the rationale is high. Some reviews recommend it also if only the main vessel is, but I disagree with this one, and I will show you why. Whilst the treating of the side branch only with the drug-coated balloon would be suitable whenever both branches are involved in the lesion. The standalone would be in line with the philosophy of leave nothing behind, which is kind of a philosophical position, like being vegetarian. I only use balloons, I don't eat meat. I mean, we should be at least flexitarian. You can like balloons, but you should remain open to implant a stent if it is needed. Whilst the treating of the side branch is more in line with the provisional stent strategy, which has been the motto of the EBC, of the European Bifurcation Club, and the KISS principle as well. How to perform the technique? Now it comes to the interesting part. So let's start by the standalone technique. It's clear. I mean, if you use a recent review published in your intervention, this is the recommendation. For the side branch, I fully agree with the recommendation of the side branch. You go there and you predilate optionally, and you apply the balloon. You can protrude as much as you want in the main vessel because the diameter will be higher, and then you are not damaging. This is an advantage as compared with the stent. I disagree, however, with this recommendation because this is against the EBC principles. You cannot size properly a drug-coated balloon that by definition should attach very well to the vessel walls if you are dealing with two different diameters which go high on a step away. So my personal approach as I try to go with 7 French for these cases. I do this technique very seldom, but sometimes you have to do it. And my approach is going with a VDCB for the distal parts. And then I do a DCB pot, proper sizing the balloons. It's more expensive, but that's I know, yeah. I'm following your recommendation to irritate you. How to perform the side branch, drug-coated balloon only. There are 2 options, using the balloon before the stent or after the stent, and we will see the evidence right now. If we are going to use it before, I mean the recommendation is pre-dilating both branches, then applying the balloon, and then going to implant the stent, pot, recrossing, kissing balloon, and repot at the end. I think everybody agrees on this. The possible flaw of this approach would be some kind of drug removal in the final kissing balloon. As we remember, in the general principles that we commented, we recommended that the drug-coated balloon to be the last step of the intervention, and in this case, it's not the last one. The other option is using the drug-coated balloon after the stenting. So in that case, we can predilate optionally the main vessel, but not the side branch, implanting the stent according to the distal size, doing pot, then rewiring, kissing, predilating optionally then the side branch, applying the drug-coated balloon, and then repot. I think this is the most reasonable way. And in this case, you don't have the risk of removal of the drug in the final kissing, but some drug could be scratched while the balloon is crossing through the stent struts. Even though you predilate, in real world, you feel sometimes very strong friction, and then you wonder how much drug is left in the balloon when you achieve the distal target. But that's the reality. In the bench stents and in the peak, everything works. But in our patients, not everything. So what's the evidence? Which of these approaches is the best? Let's start by the DCB standalone, since the EBC is running a trial right now with this approach. Let's see what's the evidence. We know that we will have positive remodeling in the main vessel and at the side branch if we go just for drug-coated balloons in both vessels of the bifurcation. Regarding other endpoints, we have very weak evidence. First of all, it's not endorsed by the guidelines right now, but we have small series, some of them descriptive, with promising results. But notice that in the second study, Bruch, the crossover, the bailout stenting is as high as 1/3 in the main vessel, and somewhat less in the side branch. But in 1/3 of the cases, you will end up implanting a stent. So be flexitarian. And the cage-free trial proves that stenting is superior to using a balloon. So this is the reality that your trial has to face right now. I mean, published in Lancet with a bigger sample size, the stent proved to be worse than using standalone technique. You will, some of them will be thinking, no, but this was before the presentation of the solution trial. The solution trial was presented at last TCT, and then a sirolimus coated balloon proved to be non-inferior to this in de novo lesions. And this is the final slide. Will this impact the treatment of bifurcations? Well, 1/3 of the patients treated in this solution trial had a bifurcation, were a bifurcation lesion. And if we go to the subgroup analysis, we see kind of neutral effect in the bifurcation, whilst in the non-bifurcation, the DEs seem to be better, but not very convincing. The bifurcations does not seem to benefit, especially from this standalone approach. Actually, if we look at the results, the sirolimus coated balloon proved to be non-inferior, but also non-superior. It's worse than the DES. Look at the results. The blue it's always slightly higher than the other one, except in cardiac death. And actually, if you looked at the MACE in general, it is at the right part. It does not meets the non-inferiority criteria, but I don't have an argument to go to my financial manager to tell him that I am going to use a technology that it is slightly worse, but not so much as disregarded, and that costs 10 times more than the stent that I could implant. Honestly, I don't see a big penetration of this technology with these current results. Something different is using the drug-coated balloon just to treat the side branch. There are two meta-analyses. This one put together 4 studies. 3 of them were clinical trials, and the other one was observational, and it didn't find any significant difference in anything. These are the clinical results. At the upper part, you see the combination of the 4 studies. At the lower part, the combination of only the randomized clinical trials. Here we have the results about the restenosis, again, non-significant. And here we have the binary restenosis. Yeah, and here we see a clear trend in benefit of the drug-coated balloon, and it is significant in the late lumen loss. Okay, but we know what we have to do with the late lumen loss. But I think the signal in the restenosis was kind of promising. There is a subsequent meta-analysis, including more studies. And here we see for the first time that using the drug-coated balloon to treat the side branch translates into less incidence of MACE from the 9th month of follow-up on. And we have also less binary restenosis. I think the authors say target lesion failure, which we understand something else, but they mean with that, if you read the paper, no difference in failure to side branch protection, that the side branch was lost at some point of the intervention. So just to disambiguate the meaning. What about, so if we agree that we are going to use the drug-coated balloon just to treat the side branch, should we do it before or after the stent? So if we go for before, we have very scarce evidence. We have this Australian study, 35 patients, and it's only descriptive, so we don't know if it is better or worse than our current standard. But well, they report some kind of promising results. 0 binary restenosis, but 1 sudden death after 4 months that was reported as possible stent thrombosis, according to the ARC definition. We have also this study from Jaén, nice city in the south of Spain, producing 60% of the olive oil of the European community. Our Greek friends probably will have some word to give. They included 100 patients, 50 consecutive in one arm and 50 consecutive in the other one. It's not ideal, it's not like a really random allocation, but it's better than just observational. They describe a procedure that might be criticized, but it's ideally correct, and they do IVUS at the end. And then, as you can see here, there is no clear significant, some significant trend in MACE, in clinical endpoints, but not significant with this sample size. So, using the drug-coated balloon before, the evidence is missing. We can do it, we can try to generate the evidence, but right now we don't have supporting evidence. The largest corpus of evidence comes from using the drug-coated balloon after the stenting. And I have selected this study that has been already mentioned several times during this morning. At the end, 784 patients randomized, and we have already described before the steps. It's quite logical because they implant the stent in the main vessel, then they do POT, optional predilation of the side branch, drug-coated balloon application, kissing balloon with non-compliant balloons. Many of the previous studies were doing we're doing the kissing balloon with semi-compliant balloons, and then repot. And the provisional arm was the same except the steps 3 and 4. So, and as it has been shown, it translates into significant clinical benefit of the treatment with the drug-coated balloon. So this is the reality. More important, if you look at the subgroup analysis, we have evidence for the first time of this intuition that Patrick Serraius had like 11 years ago. Look at the subgroup analysis of imaging guidance. If we use imaging, we lose the effect of the drug-coated balloon. So we need to skip the imaging at the end of the procedure, because only if we do angiography guidance without imaging, then we have advantage of using the drug-coated balloons. So if you like John Lennon, imagine all the people, or imaging for all the people, but not for the drug-coated balloon. That is the conclusion. So, in conclusion, we have very weak evidence for the use of drug-coated balloon in bifurcations. For the standalone approach, which is the vegetarian approach nowadays of interventional cardiology, the evidence is discouraging. I mean, right now, stenting has evidence to be superior. Maybe the EBC trial will change this paradigm, but right now, it should be avoided. I have hopes in the Medina 001. I think it's a scenario difficult to generate evidence because we all face this scenario, but not so frequently as to generate a significant volume or sample size. The side branch DCB, we have encouraging evidence in general, but for the DCB before provisional, the evidence is missing. I mean, we don't have a compelling study that proving that it offers some advantage, as we have seen. It's only non-significant trends. However, we have more evidence to use the drug-coated balloon after provisional stenting. One missing question, which maybe would be nice to address, is comparing the drug-coated balloon with a kissing with non-compliant balloons prolonged for 60 seconds. Because some DCB devil advocates say that the advantage comes from the prolonged inflation we do with the drug-coated balloon. I don't know. Maybe it would be, I'm curious to see whether this would play a role. No imaging after drug-coated balloon. After you have applied the drug, leave it in peace and don't scratch it anyway. And ignore any DCB study reporting late lumen loss. In this scenario, it is misleading, and as you can see. And maybe it's a good opportunity to set a group of experts and to summarize a consensus how to approach it, how to evaluate the angiography with bifurcation dedicated software or with some other modern tools that we have. So, thank you very much for your attention.
Very, very good presentation. And what we are facing, looking at that, is that with the complexities that we were facing for bifurcation stenting with stent a long time ago. So today, I have a lot of questions. I will ask only one here for you. You know that the curve to deployment of a balloon at the first inflation is not the curve on the box of the company. Because the first inflation is not deploying properly the balloon. Mm-hmm. So, how to size your balloon? You won't inflate 2 times. With the stent, you inflate 2 times. Not 3 times if you have the correction of the QCA. But if you inflate only 1 time, which is the goal, you will inflate 1 time. But 1 time, if you follow the curve on the box of the company, the balloon won't be on the wall. At least not along the vessel, especially in the crossover. But what to do a crossover? Another crossover. Another question, maybe a solution. You know that with the 3 atmosphere, a balloon can be open. So for the crossover, you choose a balloon at the diameter of the proximal. You add the correction for the chart, the second inflation, and you inflate at 5 atmospheres. You have 2 diameters and the balloon on the wall. So this is very complex. I agree with you. You have to build the committee that tries to solve this, maybe in bench, to see how the balloon is deployed. Because you don't know, of course,
you cannot even look where are going the crystals.
Yeah,
If the balloon
yeah.
is not the wall,
Absolutely, absolutely.
Can go distally in the LED and maybe have some trouble in flow. So
Yeah,
this is,
that's a very good point. I can remember from my, I was fellow in Rotterdam, mainly focused on invasive imaging. And at that time, we had the time domain, OCT. Probably the young cardiologists will not know what that was. But the advantage of time domain, you had to be occlusive technique, very strange things, but the catheter was very thin. It was 0014 inches. So
the balloons are semi-compliant?
Patrick,
DCBs,
I mean, Yoshi Onuma has some videos because we did some bench of using, deploying the balloon on the OCT wire. And then you can have an OCT static image how the balloon is deployed because the contrast is transparent. So you see. And
do that in a bench, it's fantastic. So you will be able to give recommendations because I'm feeling not so well. Looking at all these trials with different rules, different. It will take maybe as long as double stenting. So maybe there is a question from Dobrin.
Just first one, how do you explain that practically in the study of Gao, the whole difference between Kaplan-Meier curves comes from peri-procedural difference in MACEs? Because if you look at the Kaplan-Meier curves, you will see that the difference is practically because of the peri-procedural complications with the NC balloons. Afterwards, there is no difference between NC balloons and DCB. The statement is DCB is superior, but if you do a landmark analysis after 2 days, I'm sure that the curves will be indifferent if you look at the Kaplan-Meier curves of Gao. Because this is the study which proves that DCB is okay and acceptable for side branch treatment in bifurcations.
You mean Gao, because I presented two ones.
If you go back to your slides.
You mean the DCB BIF?
BIF, yes.
So this one?
Published, yes.
Okay.
So you see, there is a difference, but this difference is practically concentrated entirely
in the peri-procedural.
It is almost attached up to 7% with the ordinate, and practically all this difference, because I made an experiment, and I took a line between the green curve and I superimposed it on the blue line, and they're almost identical if you do that experiment after. If you do a landmark analysis, especially after 7 days, there will be absolutely indifferent because these are MACEs. In their MACEs and target lesion failure are included the peri-procedural myocardial infarction. And what is important that their NC balloons in this study are used at very high pressure, which usually I'm deeply doubt that somebody will do in regular days because this is connected with a lot of dissections.
I mean, that might be an explanation how the technique of using the non-compliant balloons, especially at the side branch, was used. However, I must say that if you look the study, they have also significant differences in cardiac death. Significant difference in cardiac death at follow-up, maybe caused by the way they use the non-compliant balloons. But I mean, it's some evidence to take into account, definitely. And this phenomenon is also observed in some other trials that we have accepted without hesitation. For instance, the October trial. If you look at the October trial, the curves are very similar. They diverge a little bit in the landmark analysis, but the main difference stems from the peri-procedural part. Of course, we accept the October trial because we all want to do OCT.
No, not at all. So, Robert?
So you really irritated me. I like it very much, but first of all, I strongly disagree with the recommendation, no imaging, intravascular imaging for DCB. This is a mistake. We know that the problem is that we know not so much. We don't understand. We don't have cutoff criteria. We don't have signals how we should follow with this imaging, on contrary to stents. Because with the stents, we can predict something based on the stable imaging, let's say images. If you look into account the mechanism of lumen enlargement after ballooning, this is a quite different thing. And main reason that the percentage of stenting increases in the cases theoretically or primarily scheduled for DCB is the fact that with intravascular imaging, we see the dissections. And in majority of us, dissections mean just a problem. Just to prevent potential problem, let's stent it. So this is one issue. And what we need much more work on that. Not just to exclude the IVUS or CT from the armamentarium of the interventionalist, rather we should focus on potential benefits which can be get or delivered by these techniques. And the second, just more remark, the weakness of all of the meta-analysis is the fact that we have to assume that there is no class effect in terms of DCB. So if you put all of the trials, but with other, let's say, other technologies, so we have something, I would say, strange. Then there are some problems in terms of protocols which were offered during these last years. We completely changed this approach compared to 10, even 5 years. And my feeling is that we have a lot of things, let's say, to be elaborate, to extract a, let's say, final decision. And what we also need, we need head-to-head comparisons between these balloons.
Absolutely. Let me, I was a little bit provocative with the imaging. I think we can use imaging before the drug-coated balloon. And maybe we will have a better insight on the vessel size. We will understand the plaque composition, whether we need a different plaque preparation. That's okay. But after the drug-coated balloon application, then that should be our final step. That should be our final step.